Thank you. Sorry, I'm just getting the Mac working, and hopefully we'll switch over. Brilliant. Thank you very much indeed. Right. I'm going to do a bit of speed dating. So it's literally a Cook's tour through some of the big papers. As Ed was saying, you know, the main focus will be on the big papers and the big journals, but I've thrown in a few other sort of things that have grabbed me in the past few years. So, you know, recognising that you guys have to go out and save the bloody thing. Do you like the accent? No, not very good. I try my best. My children groan when I try accents, so I'm not going to go any further. Okay, so what I'll do is I'll keep bashing on until either you've had enough, or more importantly, the chairs have had enough and they ding the glass. So let's go through septic shock. So you've all heard about, obviously, the process trial and the ARISE trial showing no difference with early goal-directed therapy. Why? Good question. This is actually quite interesting. It was now with big data, you get thousands, millions of patients being collected into hospital electronic medical record systems, and you can really mine that data. And these are two systems in the US which were mined to look at patients with sepsis. And it was a letter in JAMA, and what they looked at were patients who got early goal-directed therapy against patients who didn't. And interestingly, there was a big difference in mortality, from 17% up to 28% if you didn't get it. So it may be the sheer fact you were enrolled in a trial and you had a research nurse looking after you for that 6-hour period made a difference, because wasn't shown in the trials, but here, if you didn't get it, you did worse. So it may be a selection bias. Why did some people get it and some didn't? But it may also be the fact that somebody was taking an interest in you. They also, and I think we need to personally revisit lactate, because I think too much emphasis has been put on lactate as a marker of shock. It's actually, biologically, it's not that strong, and there are lots of other arguments for lactate going up. But again, from this database, they looked at patients who had a normal level, an intermediate level, where the levels were between 2 and 4, and the mortalities went up from 5 to 9. But here, when no lactate was measured, the mortality was even higher. It was 10%. Why is that? Well, they found that sepsis was a very common cause of death in these hospital cohorts. However, you know, the majority of them, over half, were patients with sepsis who came in with a normal blood pressure and a normal or a not very raised lactate. And they make the point that patients with initially less severe sepsis made up the majority of deaths. So our focus has been very much on this early goal-directed therapy as they come through the doors of the emergency department, but probably our main emphasis should be on the patients who are admitted to the ward and then fall in a heap afterwards because they're continuing to deteriorate despite being admitted to a hospital. So we've heard, and I touched on some of these yesterday, but apologies to those who were here. I'll just very briefly repeat. There was a study looking at high versus low blood pressure. I couldn't see the logic for that except in patients who were chronically hypertensive, and they enrolled 776, either to keep a mean blood pressure at 80 to 85 or 65 to 70. There was no overall difference. But if you delve into the paper, the patients who benefited from the higher blood pressure were those who were chronically hypertensive. Perhaps not surprisingly. What isn't mentioned, and there was a trend, it wasn't significant, but those without chronic hypertension trended worse. They don't mention mortality data, but certainly in terms of renal function, need for filtration, creatinine, got much worse in those who had a normal blood pressure before they got poisoned with the noradrenaline to get their blood pressures up too high. I also mentioned the Albios trial. This is albumin being given to patients in the hope, because there were some studies suggesting that albumin has magic properties, and if you get the albumin albumin up in these hypoalbuminemic patients who are septic, they do well. Unfortunately, didn't show it. There was some post hoc analyses that showed the sicker patients seemed to benefit, but the problem was that in half the patients, they didn't get to their target of 30 grams per litre, so they didn't give it a chance to work because half the patients didn't actually get to the target. What about blood? Again, we've been relying on the Canadian study, the TRIC study from many years ago, that a transfusion threshold of 7 is a good idea. The Scandinavians have now repeated that study, looking at a threshold of 7 versus 9 in patients with septic shock, to see, does it make a difference when you're in an ICU with shock? And basically the answer was no. They were able to get a good separation between the groups, and they found that it made no difference apart from the fact you saved a bit of blood, which, again, with all the stuff about chronic effects of blood transfusion and long-term effects on cancer risk, etc., may not be such a bad thing. But certainly there was no benefit to a population pushing the hemoglobin up to 9 versus 7. And there's the Kaplan-Meier curves. Ed mentioned this trial recently. I was involved with it, which is quite an interesting trial because the logic was there, but unfortunately the results didn't map out. And even the phase 2 trial results were positive, encouraging, but the phase 3 failed. And so the idea is hemoglobin binds nitric oxide, and that was a way of getting the blood pressure up without poisoning patients with catecholamines. Unfortunately, the outcomes were worse rather than better, and the sicker the patient group, the worse they did. Some post-hoc analyses showed that patients with high nitric oxide levels, or nitrate levels measured in the blood as a surrogate, were those who tended to do better with the drug. So again, it may be that everybody shouldn't get the drug. If we can find the right patient, there may be a benefit for that subset. Which leads me on to esmolol. I don't know if you read this, I was involved with it. It was a single centre study from Italy where 154 patients were randomised to either get or not get esmolol beta blocker, a short-acting beta blocker, and this was a specific subgroup who after 24 hours of septic shock were reliant on a lot of noradrenaline still and were tachycardic. So you had to have a heart rate of over 95, and this is a high-risk mortality group. And what they did in Rome was Andrea Morelli was the lead author. The esmolol was titrated to get the heart rate to between 80 and 94. And it worked in terms of, the trial was designed to see could you safely and successfully do so, and clearly they were able to do so. The control group, the esmolol group in terms of heart rate, yet the blood pressure was maintained. The norepinephrine dose came off quicker with the beta blocker. Again, another talk, I can explain why over a coffee or a beer, but the noradrenaline dose came off a lot faster when the patients were given beta blockers. There was improvements in renal function. Troponin levels, which are a marker of cardiac injury and sepsis, were much lower in those those given the beta blocker on top of the noradrenaline. And the thing that's got lots of people talking, there was a big outcome. Mortality reduction. It was sort of halved. Everyone focuses on the fact that, look at the high mortality in the control group. This was a severe subset of patients, but it was halved with the esmolol. Goes against the grain, doesn't it? Beta blockers in septic shock. Again, my experience, we're using it. We haven't yet done it on a control trial basis, and we're trying in the UK to put together now a grant application to look at this. But there is a good rationale, whether it's because of the heart rate reduction, because there's evidence that actually reducing heart rate is good for you in cardiac conditions, let alone sepsis. But also there's lots of other effects of beta blockade on inflammation, immunity, metabolic efficiency, etc. This came out last week in JAMA. It was presented at the European Congress in Barcelona. Vitamin D is a single-centre hospital study in Graz in Austria, and they randomised patients over a 2-year period, 2.5-year period, 5 ICUs within one hospital, and they gave nearly 500 patients with vitamin D deficiency. Half of them got D3, half got placebo, and they continued it for up to 5 months. Overall, there was no statistical significance, nearly but not quite. But those with a severe vitamin deficiency, there was an outcome benefit. Ooh, it's cheap, vitamin D. It's not obviously known to be harmful. Should we be giving our vitamin D patients vitamin D? I'm sure a lot of places will start giving vitamin D. I think rightly the authors caution on the basis of a 200-patient subset saying, well, hey, this is interesting, but we need further studies to make sure this is a real effect rather than a chance effect. Okay, moving on, infection. There's been quite a few interesting infection studies which actually feed my bias. This is nothing to do with intensive care, but it was a big Danish epidemiological study showing that azithromycin increases your risk of death from cardiovascular causes of death, heart attacks, whatever. And there was a risk increase of 2.85-fold increase if you got a 5-day course or more of azithromycin. When they compared it against patients who had had recently penicillin V, it made no difference. So here's the sort of little graph, and you can see here that compared to placebo, if you didn't get an antibiotic, you did much worse, but compared to penicillin V, no difference. Which leads me to think, well, perhaps just giving an antibiotic is bad for you. Shock horror. Even a 5-day course. Shock horror. And I think we need to look as a community at how we give antibiotics. I think personally they're doled out far too readily. And now people are talking about antibiotic stewardship because of resistance. I think it's much more than that. Antibiotics are toxic. They are evil, dangerous drugs. Used appropriately, they're great, but they do carry a risk. And so if they're not used appropriately, that risk is there to the patient without any benefit. I mentioned this yesterday, the Kumar study. Every hour of delay in giving a right antibiotic if you're in shock increases your risk of dying. But I would argue it's not particularly plausible from a biological point of view, this stepwise decrease hour on hour. And if you actually read the paper, they excluded patients who had been started on an antibiotic before the onset of shock, and their mortalities were actually better than those started after, for the first 4 hours of shock, so it doesn't quite fit. Recently, Mitch Levy and colleagues from the Surviving Sepsis Campaign, they looked on the statistics on their registry data and said, it's the same not just for shock, but sepsis in general. For every hour of delay in giving the right antibiotic, there's a mortality detriment. Is that true? Don't know. We haven't got the trials, but there is a huge literature that actually says the opposite. This is going back to 2007, looking at studies, looking at the association between appropriate antibiotics and mortality in bacteremic patients. And just under half actually couldn't show any relationship. However, all of these studies were criticised. They were retrospective, the methodologies were weak, and there were multiple limitations. And there are some more recent studies. This is one of them. This is from Germany. Their objective was to look at Staph bacteremia and what was the impact of a delay, because clearly, early broad-spectrum antibiotics reduces mortality. They looked at it, and unfortunately, the hypothesis was defeated. The mortality, if you can see here, 35% if the patient was given an appropriate antibiotic, but only 28% if they weren't given the right antibiotic. And there are lots of other data to also support that sort of finding. So it's not as clear-cut as perhaps we've been led to believe. And they concluded, within the limitations of this and previous studies, a delay in therapy may not influence survival as strongly as widely perceived. This is my favourite trial. It's of the 2012. Fascinating trial, very brave trial. Brave because it was done in the highly litigious United States of America. Came out in Lancet Infectious Diseases. It was NIH funded. And what they did for a year, this is University of Virginia, surgical ICU, for a year they did their normal practice of giving antibiotics when they recognized infection. And for the following year, they didn't. They didn't give any antibiotics until either they had a positive blood culture or a normally sterile fluid showed a gram stain positive sample. So there was an intrinsic delay in starting antibiotics. Brave? Goes against the grain, doesn't it, of surviving sepsis, etc. And what happened? Their primary outcome was mortality. And essentially, they had about 250 in the first year, 250 in the second year. The mortality in the first year with the aggressive antibiotic treatment was 40%, and it was about half when they waited. And when you adjusted it for various sort of individual sort of variations, the adjusted odds ratio of death for early aggressive antibiotics was increased by 2.5. And here they looked at a subset of patients with shock, and they defined shock as a mean arterial pressure below 60 in the presence of an infection, had about 100 in each group. The time from blood culture to initiation of treatment, if you look at the median, from 4 hours to 20 hours. And what happened to the mortality? Reduced from 66% to 26%. So I'm not saying change your practice. I wouldn't. If I was sick, I'd probably want a gram-negative antibiotic if I had gram-negative sepsis. But I think the story is not as clear-cut. And to me, this is a really fascinating trial because it really shakes the tree up. Just because we have perceived wisdom, this must be right, may not be. Another good idea, but unfortunately fell by the waystream, was this French trial looking at bacterial meningitis. And the idea is perhaps temperature's a bad thing, although that's an innate part of evolution. And so let's see what induced hypothermia does. So they randomized patients with meningitis to get some loading dose of saline, and then they were cooled to 32 to 34 degrees for 48 hours, and then gradually rewarm them. And after 98 patients, they had to stop the trial because of harm. There was an increase in mortality. Most of the patients had pneumococcus, but clearly the outcome was going in completely the wrong direction. This came out, again, one of the things I hate infection control. It's important, isn't it? But where's the evidence for any of it? And so when I ask, the sort of clipboard Nazis when they come round, certainly in the UK, do you have them in Australia? Yeah. And I say, well, have you got any evidence for any of this? And they say, Semmelweis. And I say, well, yeah, that was 1856. Anything more recent? And they go, well, there must be. And I said, well, if there must be, surely you know it. And they go, well, there must be. And it's a horribly grey zone. We did a little survey just in the London area, and every ICU did infection control differently, which implies that there's no knowledge base or evidence base because everybody does it differently, and that's within a relatively small geographic area. And so there have been recently a few trials trying to see what we should do, because lots of things are implemented without any evidence base, and it costs a huge amount of money, it's a huge amount of time and effort, which perhaps could be, and cost, which could be perhaps diverted more effectively elsewhere. This is a trial from the US where they gave three strategies in adult ICUs: MRSA screening and isolation, targeted decolonisation, which was screening, isolation and decolonising MRSA carriers, and universal decolonisation, where they didn't bother screening, they just decolonised everybody. And they prevented one bloodstream infection for every 54 patients who underwent decolonisation, because that's where the most bang for your buck was. So there was nothing on overall outcomes. There was no report on a benefit in terms of mortality, but certainly in preventing 1 in 54 patients from getting a bacteremia if you didn't bother screening. This meta-analysis came out in the BMJ recently, looking at all these, there's a lot of interest at the moment about selective gut decontamination, etc., etc. Personally, I think it's a huge amount of work for relatively little gain. You've got to treat 50 patients to save 1 infection. Will it make a difference in mortality? Again, the studies don't actually indicate that. Perhaps I'm a bit of a cynic. But interestingly, what they did find in this analysis, and I've shown it here, was that patients who were just given chlorhexidine did worse. When they put all the trials where people had been randomized to get chlorhexidine or control on in general, and the analysis came out as just about positive, that you did worse if you got chlorhexidine. Again, it's a meta-analysis, it needs to be prospectively confirmed. But it is interesting, our efforts to do good may actually cause harm. Just like hand gel, we didn't have a problem in the UK with C. diff until hand gel came in, and then all of a sudden we had a problem with C. diff. And then the Department of Health went, whoa, 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 don't use hand gel with diarrhea, go back to soap and water, and then the problems receded. So we've caused our own sort of crises. What about gloves and gowns? I looked a couple of years ago on our ICU, we spend £120,000, which is about 200,000 Australian dollars every year on disposable gloves and gowns. Huge amount of money. That's my little ding, so I'll finish in a few minutes. But essentially, they looked at this trial looking to see, will it make any difference in terms of MRSA and VRE? And the answer was, no, it didn't. And what they did find was that having gloves and gowns before you went into a cubicle decreased the number of visits the patients got. It's known that shoving a patient into an isolation cubicle or whatever means they get neglected. Adverse events go up, patient satisfaction goes down. And again, here they documented the same thing. There were fewer visits. I'd better finish there. I've got lots of other things I can talk about, fluid, nutrition, etc. I don't have time, because I got the ding, but I'll gladly talk about those if you wish later on. Thank you very much for listening.
To invite some questions from the audience, but I was fascinated about the observation with the hand gel and the Clostridium difficile. Can you just explain the proposed mechanism?
It was known about. In fact, I've got stuff from CDC in Atlanta actually said, I've got things from 2002 that don't use hand gel because it doesn't get rid of the spores. So it was known about, and then it got introduced into the UK because clearly hand washing must work, it's good for you, and people weren't using enough soap and water. So hand gel was brought in as a convenient sort of substitute. And there's a beautiful correlation with a rise of C. diff. And then interestingly, then the Department of Health, when it became a big problem and the newspapers were picking up on it, perhaps we know it doesn't get rid of the spores, perhaps go back to soap and water when the patient's got diarrhea. C. diff's gone down.
I'm fascinated about all the insights about antibiotic use and potential harm. How do you think we can explore, we're very easy and early to prescribe antibiotics.
Yeah.
How can we explore this further?
I don't know. The good thing about the UK, traditionally, we have and I don't know about Australia, so you guys can tell me, but we have a very limited antibiotic policy. So the average course on my unit, we literally just published a few weeks ago, it's just come out. We look at our practice and look at resistance rates and so forth. We give a 5-day course on average for peritonitis, pneumonia, whatever. Unless the patient's got osteomyelitis or endocarditis, some deep-seated infection, we give 5 days and then stop, sometimes even less. And we have, as I said, we just published it, very low resistance problems, very low fungal problems, etc. So there must be some sort of relationship. If you go to mainland Europe, huge problems with resistance. There was a nice trial from Charlie Sprung in Israel where they looked at patients, half the patients given an antibiotic within a day, they'd worked out that they didn't have an infection. Yeah, oh, well, we'd better finish off the course of antibiotics. So these patients who were, after a day, thought not to have an infection, got 9 days of treatment. Yep. So I think we're creating our own monster. And I can give you a whole list of problems that antibiotics cause. And so I think we're too complacent about antibiotics. And to my mind, they're good in their right place, but we just dish them out too quickly. And I think now there's a lot of comeback about, because they're used as a quality target. Have you given your antibiotics for somebody coming into casualty with a chest infection or sepsis? Boom! Or presumed sepsis. And now, even in America, the Emergency Medicine Society are actually railing against that and saying, don't use it, because people are being overprescribed antibiotics.
All right. I think we'll wind up the session. Thank you very much
Pleasure.
to all of our presenters.